We are live.
Okay. So, good evening, postgraduate, and welcome to this 88th episode of All India Online PG Teaching Program, an initiative from AIS ARC. So, now following four PG programs, we are going to have on research methodology, so that it is aptly titled as Exploring A to Z of Research Excellence in Ophthalmology. Let me now, without much ado, hand over the proceedings to our co-chairperson and member ARC East, who is responsible for designing this next four episodes for all of you postgraduates. So, Dr. Kasturi ma'am, over to you for further proceedings.
Yeah, can you hear me?
Yes, ma'am.
Okay. So thank you, Dr. Prashant, the chairman of AIS ARC, and it is with great pleasure I welcome all of you to this webinar. This is basically, we'll have four sets of this webinar covering everything A to Z of research, especially in relation to ophthalmology. Very much honored, very happy to have with us Dr. Usha Singh. Dr. Usha Singh is the current president of the Oculoplastics Association of India and also the professor at Advanced Eye Center, PGI Chandigarh, and also to have Dr. Parul and Dr. Shubha and Dr. Rolika and Dr. Sonali with us. And we are very honored to have two of the best speakers who will be covering very important topics. First by Dr. R. Narayana and next by Dr. Parul. So now the whole of this program will be moderated by Dr. Parul and Dr. Shubha, who will be there for all the 4 days. We are having this program every Thursday for 4 consecutive Thursdays starting from 8 and we'll try to finish within an hour's time. So the main moderator will be Dr. Parul and Dr. Shubha. So I request Dr. Shubha to kindly introduce all the other eminent personalities who are with us today.
Good evening, everybody.
Shubha, can
Yes,
you
ma'am.
introduce Parul madam?
Yes, ma'am.
Before you introduce Parul madam, let me introduce Dr. Shubha. Dr. Shubha is one of the budding, but a very good, I should say, oculoplastic surgeon and also tremendous work in ocular oncology. He had done his fellowship under Dr. Santosh Honowar. Very sincere. At a very young age, he had received so many accolades, and he's with me for this 1 month, and I could see how sincere and also how passionate he is in relation to oculoplasty and oncology. So lots to learn from all these youngsters, and so happy to have you with us today. Over to you, Shubham.
Thank you so very much, ma'am, for the kind introduction. Today we have with us experts in the field of ophthalmology to guide us into this research methodology. And I'm thankful for the opportunity to co-moderate this session with Dr. Parul. Dr. Parul, who also happens to be the speaker for tonight. I shall be introducing her in great detail in the second half of this program. And we have two distinguished speakers. Along with Dr. Parul, we have Dr. Raja Narayanan from LV Prasad Eye Institute to speak to us on today's platform. And along with us, we have two other panelists, Dr. Rolika Bansal and Dr. Sonal Kalia. Dr. Bansal is my mentor and senior at Center for Sight and Ocular Oncology Service, who trained me with Dr. Santosh Hanawar and also holds two international fellowships, one at Wills Eye Research Institute, and currently she's pursuing her second fellowship with Dr. Don Kikawa, and she's stipulated to be in India in July this year to advance her training and her practice in Indian ocular oncology services. And we have Dr. Sonal Kalia as the other panelist, who happens to be a gold medalist in MS Ophthalmology and is currently serving as the associate professor at the upgraded Department of Ophthalmology, SMS Medical College, Jaipur, and is the immediate past president of the very dynamic Young Ophthalmic Society of India. With this, it's a pleasure to introduce Dr. Raja Narayanan. He is a network director of the Human Resources and the Anand Bajaj Retina Institute and the director of the Suven Clinical Research Center. Is a consultant ophthalmologist with a specialization in vitreous retina services. He's the principal investigator and the co-founder of the Indian Health Outcomes, Public Health and Economics, that is the iHope Research Center. He has his basic medical education from the Delhi University, the Masters of Surgery and Ophthalmology from GNEC, with preceptorship in uveitis, ocular immunology, and uveitis service at the Mass Eye and Ear Infirmary at Harvard Medical School, Boston, and fellow in medical retina and clinical and research fellow in vitreoretinal diseases at the Department of Ophthalmology, University of California. He received the very prestigious Sir Ratan Tata Fellowship in Cataract Surgery from Shankar Netralaya, Medical Research Foundation, Chennai, and a recipient of the Senior Honor Award from the ASRS and the International Ophthalmic Education Award at the American Academy of Ophthalmology. He's a visiting faculty at the University of California and visiting scholar at the Mass Eye Ear and Infirmary, Boston. He's published widely in peer-reviewed and index journals and happens to be the editor-in-chief of the iHope. With this, I request Mr. Sunil to play the video of Dr. Raja Narayanan.
Good evening, everyone. Dr. Raja Narayanan. I would like to thank AIS-ARC for giving me the opportunity to present on this very important topic of ethical and regulatory considerations in clinical research. I would say that it's very important to know all aspects of clinical research. It's very good to know how to write a paper, how to conduct a research. But if you don't know this topic, ethical and regulatory considerations, it may cause significant downfall of very well-established and reputed researchers. So this has many aspects in terms of what comes under ethics. Anything that involves humans, biological material, or data, and it can be in any form, such as academic research, thesis, projects, even surveys or questionnaires, or psychological or behavioral science. So what needs to be complied with in clinical trials? It's established in IRB approved protocols, and there are standard operating procedures. Good clinical practices is what we will focus quite a bit today, which every clinician, which every doctor should know. Whoever does even little bit of research, they should know the GCP. It's good to be GCP certified, and we should all know about the applicable local regulations. So what is the clinical trial? It is the study of a new drug or investigation new drug in human subjects, which could be clinical, pharmacological, and also looking at adverse effects with the objective of determining the safety, efficacy, or tolerance of these new drugs or products. An academic clinical trial is a research conducted on a drug which is already approved. Usually thesis for postgraduate students are an academic clinical trial. Usually they are not something totally new drug, something which has not been tested in humans earlier. So an academic clinical trial is something which is done to extend an approval, or let us say something of a new indication of a subgroup of already existing disease for which a drug has already been approved. And the results of such a trial would be intended only for academic purpose, and the drug licensing authority, that is the DCGI or FDA, is not going to give any approvals or new labels based on these trials. So you should always take ethics committee approval for all clinical trials. And if there is any doubt, you should ask the DCGI whether any further approval from the DCGI is required or not. But all clinical trials must have ethics committee approvals. I would also encourage that all prospective trials should be registered with the CTRI or Clinical Trial Registry of India. As you can see, the website here is listed here for all prospective clinical trials. Usually, all journals ask for these new studies, prospective studies, to be registered with them for publication purposes. So the ICH GCP, which I was mentioning earlier, it's a very important topic. It was the latest version was released in this year in January. It refers to the good clinical practice, which establishes the ethical and quality standards for designing, conducting, recording, and reporting of trials involving human subjects. The latest version is GCP E6R3. The GCP guidelines are mainly to protect the patients. It's very important for our patients' safety. Otherwise, we know from experience over the last many decades that patients can be made as guinea pigs. We should never ever do that. And patient consent is also a very important part of that, which is a voluntary consent. GCP is also has guidelines for quality of data, mainly ensuring that the data which is generated from these trials is valid and reproducible, is not falsified. We should never ever have falsification of data, which is totally unethical. When I was mentioning that history has numerous examples of unethical research, you can see all these which are listed here, which led to big human tragedies. We should never ever do something which we will never be part of. And that is why we have the GCP guidelines. It has different principles. Out of these 13 principles, the most important is about rights, safety, and well-being of our patients. And it prevails over interests of science and society. Even if we as doctors think that this is probably one of the most exciting developments, something which will change the patient's disease, but patient's safety, rights, and well-being are more important than what we think is very important for a disease. And informed consent, as I mentioned earlier, is at the heart of any research. So informed consent is not a piece of paper. It's not about signature. It's about the process, making sure the patient understands, or the witness or the guardian of the patient understands that what they are giving consent is with full understanding of the risks and benefits of the study. Full information must be given. It should not be a hurried process. We should never tell a patient to sign or coerce them to sign. It is absolutely voluntary, and the patient has a right to withdraw from the research at any point of time. The patient may give consent today and withdraw tomorrow or after a month or 6 before the study ends. And that is well within the rights of the patient. So these are the elements of informed consent. And one of the important things is to tell the patients that there are alternatives available, which is called a standard of care, and the patient is free to choose the alternatives or the standard of care at any point of time and withdraw from these trials. It should the consent should have the signatures uh, of the patient or the legally accepted representative and an impartial witness. That is because there may be some vulnerable participants. Vulnerable because of social weaker people from the society, economic, poor patients, physical, those who are disabled. And also we see a lot of research being done in, let's say, companies or organizations where the lower strata of employees are made to participate in some form of trial or questionnaire or survey. For example, if you are a hospital, it is very easy to have MBBS students to may force them, or postgraduate students to force them to participate in either a drug trial or a diagnostic study or even a questionnaire. So it's very important that we don't misuse this, and any of these student population uh, or vulnerable employees are not targeted. And all the responsibilities and accountability ultimately rests with the principal investigator. So the principal investigator is the main faculty, consultant, or the doctor or clinician who is performing the research. That person is supposed to be qualified by education, training, and experience and comply with the GCP or Good Clinical Practice guidelines. That's very important. And they're responsible from the beginning to the end to all aspects of that research. And ethics committee approval is always necessary for any form of clinical trial. We should know who all are the members of the ethics committee, what is its authority, and what are the roles, and we should not start any trial without the prior approval of the ethics committee, which is an independent body. So ethics committee is not a department of the hospital or medical college. They are totally independent, made of professionals and non-medical members from outside the organization as well, to mainly protect the participants or patients. And it is required by law, including NABH and DCGI. Approval should be there for the ethics committee, and they should act independently, and the members should not have any conflict of interest with the study being voted upon. So the EC can give a favorable opinion or ask for modifications or completely reject a proposal, or at any point of time suspend a previously approved study. While there are can be different members of the ethics committee, I would say that the lay person is someone who is very important and gives the public assurance that this is a fair and ethical process of approval going on in this ethics committee. And they also have to vote on any project. Any person who has a conflict of interest is not supposed to vote on this. So an EC or IRB can do a study review, and that is to mainly assure the protection of the rights and safety of the human subjects, and the scientific rationale, risk benefit, informed consent, participant protection, all these are looked at by the ethics committee. Any amendments have to be informed. You change the protocol in between the study, you have to inform the ethics committee immediately, and any non-compliance must be notified to the ethics committee immediately. And the ethics committee has lots of oversights. How is the study going on? How is the site doing? Are risks are the same as in the beginning of the study, or have new risks come up, and if required, you may have to change the consent form and inform the patient. Those are already there. You may have to reconsent, saying that this drug has no new side effects, but do you still want to continue in this study or not? So these are very important oversight functions of the ethics committee, and they are also regulated by NABH. And if we understand all the other aspects of clinical research, which I'm sure you will learn in the due course of time about the clinical research methodology, what are the ways to conduct a study, how to write a manuscript, how to analyze data, different types of statistics, and along with good ethics, you can always get very good publications. But I would again like to mention here that it is very good to do highly ethical research, but it's better not to do research if it is not ethical and not done with integrity. And who is the best judge? You are the best judge in these cases. But again, let's work towards improving our patients' outcomes, their treatment effects, but at the same time, protect their safety as well. So, whenever there is any doubt, stop. No study is perfect. Acknowledge limitations, but don't do any unethical work or falsify the data. If you are interested in learning further about good clinical practice, you can go to this website listed here and look at various research methodologies as well as the GCP course which is available. Thank you for your kind attention.
Thank you. Yeah.
Yes, thank you so very much, Dr. Rajanarayanan, for such a insightful talk. In the view that you are traveling and still within the transport medium, we would postpone the questionnaire to the end of the session. And now I would request Sunil ji to just have Dr. Parul's slide for introduction on our screens.
Just give me 10 seconds, sir.
Sure.
Can I ask one question to Dr. Rajanarayan? Like you have mentioned about the ethical issues while conducting research, but what about the vulnerable population, like the children or mentally retarded, or those from a poor economic background? So, are there something else additional we need to deal with them, especially this vulnerable population?
Yeah, thanks for that question. As I had mentioned, there can be many categories of vulnerable populations. I had mentioned different like socioeconomic, mentally challenged or physically handicapped, or even sometimes, as I said, if the boss is doing a trial on the subordinates, right? So it can be vulnerable. The employee may not be able to refuse to participate in a trial. So these are the kind of things which the ethics committee has to look at and make sure that uh, whatever is being done, no undue advantage is being taken. But sometimes, let's say you have some studies, let's say pediatric patients, right? So there may be some trials which have to be done, but the process will be very strict. The consenting has to be very strict, that the parents are explained everything, and in even otherwise, guardians, they have to be in cases where you may have to look at a certain kind of population. You may have to look at these very carefully, and the ethics committee's role becomes very important in these. But they have, they specifically look at these vulnerable populations. Now these are very strict rules. Now there are some kind of people or organizations or researchers who say that these are very strict for our kind of studies. For example, if it's a public health study, let's say you want to give nutritional supplements in pregnant women in the population, right? And you've decided on certain clusters of villages, and you say my new supplement improves anemia or hemoglobin in the general population. And if you ask, then my sample size in the public, in a public health study is, let's say, 5,000 patients. And if you ask me to go and ask for a consent for each and every individual in the population, it's going to be very difficult. So some people say that I should be able to get an implied consent if the let's say the local panchayat or the group head it approves the study. You can't be explaining to each and every one. So these are balances and counterbalances which always keeps on coming, but ultimately everything is related to patient safety. And yes, we should be very, very careful about this. Yeah.
I'll ask you something very simple question. Like when you were mentioning about GCP for the ethics committee, like the members of the ethics committee are some real, senior people, and with from different background. So how do you train up these members of this ethics committee? Like they have to have the GCP certification for which they need to go through all the details and before they sit for their certification exam. So do you have anyone in your institution who trains up them or any other system?
Yeah, so these members have to be GCP certified. So all members have to attend these courses. These are usually 1 or 2 day workshops, and they are trained and retrained as well. Usually they are already experienced people who need to be on these committees, who they may already have these certifications. But yes, there are training courses for them. What I have showed on the one website which I have shown, which I hope has created, it's something which you can complete in, let's say, 4 to 5 hours on your own. But you may have to take additional courses as well if you want to be an ethics committee certified member.
I have a question for you, Dr. Narayanan. Where do you place video consenting in this entire gamut of taking assent and consent?
Yeah, so video consenting, for at least typical clinical trials, let's say FDA trials. Now DCGI mandates that we should have audio visual consent. Now that depends on the DCGI updating these rules now and then. So sometimes earlier the audio visual consent was not required now, but we are doing it now. But at any point of time something needs to change, they can change. But it's very important. The overall point about consent is not the signature, it's the process. And that's where the audio visual recording actually captures the entire process of the consenting. And it's not just one dotted line and you say that patient has signed. So it's unfortunate that many people think that if a patient signs on a consent form, I am free of any liability. No, because was the patient described in a language, what is this trial, what does the drug, what are the side effects, was the patient given enough time? Patient needs consent forms can be anywhere between 5 to 15 pages. Can the patient even understand and read and come back to you in 1 minute and sign? So typically we have to give these consent forms for them to take home, read, and after a day or two only you should come back and sign these consent forms. So these are the usual, styles of consenting, but it's a process. Now, I would say that it's good for the doctors and hospitals if a video recording is taken. It makes us more reliable. It makes us more safe. But the key point is even when you record, you just can't say it's not a one-sided conversation that the doctor says this is the trial and this is what is going to happen. You'll be given this treatment free of cost. You have to come for these visits, and these may be some side effects. You just rattle out no, but you should ask the patient, have you understood? Do you have any further questions? And if they have any questions, it's a very good sign that the patient is understanding what you are saying. So it's never a good sign if the patient says, I have no more questions. You may feel happy, okay, my first patient is enrolled or my 50th patient has been, my sample size is getting over today. But it's not a good sign if the patient does not ask some questions. It's always a good sign to ask questions.
So
So
we
on the-
also know that these are not liable to be held in court. Like any of the informed consents can be declared as null in the court in case of any inadvertent complication. So do you think that the video consents will have a better hold in court, just in case from the legal aspect?
No, see, as I said, taking a consent does not absolve the liabilities which are expected as a standard of care. Okay, if you do anything which is not acceptable as a standard of care, which is what the courts will decide or look at. But at least video consenting, if you've done the consenting the right way, you have explained each and every side effect and also mentioned that you can withdraw from this trial at any point of time without any questions. Now, these help build the credibility that you did not force a patient into a trial. Okay, but you still have to maintain those GCP standards which are required. So consent is just one part which they will be evaluating. But if you have done a good consent process, it's a plus point. But if you have not done any AV consenting and just taken a signature and the patient says tomorrow, I was never explained anything, I did not understand. I was just asked to sign here, then patients' words carry more weight. Even if you say, no, I spent 15 minutes explaining all these things. It's good in a way to have these AV consent, but it also, what these trials have taught me is that this is how a normal process, let's say you want to explain cataract surgery to a patient, a routine cataract surgery, you will know how to take consent from the patient, even though it's not a trial. You still have to talk to the patient and tell this is how the process will be, and this is how normal side effects are, and let the patient ask questions. Doctor, मैं ठीक तो हो जाऊंगा ना? But as soon as they say and say, no, you will be all right, come. No, let them ask questions. That's the best way of interaction, even as a doctor. That builds trust, patients they really love you if you let them to ask questions.
So we also have a question from one of the panelists. Is it okay if I go ahead with the question?
Yeah.
Yeah. One of the questions is, should consent have percentage chances of complications listed within the form?
Now, whenever we have complications, there are different ways of putting it across. But I would say one is percentage. Yes, it's very difficult to say 1.9% of patients had endophthalmitis unless there was only one study which was conducted and you have that. But if you say, let us say reasonable level, approximately 1% of patients have this complication. That's also fine. Okay. But if you have, let's say, intravitreal injection studies are there, the most common side effects are pain, redness, and watering for a few days. Okay. And then you come down to other side effects, like you may see floaters, um, you may have some haziness of vision for a few hours, which will go away after some time. And then you come to the more serious complications, let's say endophthalmitis or severe inflammation, which are seen in less than 1% of patients. If you put it across like that, you have covered all aspects. So it's not necessary. I mean, whenever we talk about side effects, it's not that we should always only talk about the very serious side effects. You talk about the common side effects, which are not very serious also. That also builds a level of trust. Okay, and it makes it easier. You have already started communicating with the patient. Patient also now is looking up to, okay, these are common side effects which are acceptable to me. And then you say, if there are some side effects which are very serious, which can be very unfortunate, what will happen in that situation? Will you take care of my treatment? Am I covered for these eventualities? And by law, in a trial, at least the phase 1, 2, 3 trials, which the pivotal trials, you have to take insurance for these patients for any liabilities also, for any eventualities also. So that's how it works. But I would say that, it's not specifically about the exact percentage, but you can categorize them: common, less common, and very infrequent kind of side effects.
Thank you,
Thank you,
Dr.
sir.
Sir, for answering that question.
Shubha?
Yes. Thank you so much, sir, for that answering of all those doubts and questions and for an insightful discussion. May I now request Sunilji to have Dr. Parul's introduction on the screen? It's a pleasure again to reconnect and introduce Dr. Parul. She is a professor in glaucoma neuro-ophthalmology services in the Department of Ophthalmology, Government Medical College and Hospital, Chandigarh. Her keen areas of interest include the visual function, glaucoma imaging, neurodiagnostic smart applications, medical management of glaucoma. She received a training in glaucoma from the Advanced Eye Center, PGI MER, Chandigarh, India, and a clinical research fellowship under the prestigious aegis of Dr. George Spieth at the Wills Eye Institute, Philadelphia, USA. She's enlisted in the power list of Best 40 Under 40 Ophthalmologists in 2015, received the honor award for contribution to the field of ophthalmology at the 6th Annual Conference of the Middle East Ophthalmic Society 2024. She's received the Young Ophthalmology Teachers Gold Medal at the FOTI 25, member Associate Advisory Board to the World Glaucoma Association. She's the member Education Committee at the World Glaucoma Association as well. Made indexed articles to her name. She's CEO in glaucoma. She's associate editor, Journal of the Current Glaucoma Practice and Frontiers in Ophthalmology, and editorial board member of the IJO and the AIOS Times. Over to Dr. Parul for today's talk.
Well, good evening, everyone. It's a pleasure to be here and to talk about research methodology and study design. So these are the baby steps to research methodology, which you would be learning in the subsequent 3 webinars as well. So if we knew what we were doing, it wouldn't be called research, would it? So Albert Einstein has beautifully put this statement across. And with this, I'll just share a small anecdote. So in the early 1900s, Dr. Wolf was doing research about finding out the iron levels in spinach. And by mistake, the data that came out had a misplaced decimal. So the value of iron in spinach was taken out to be 10 times more than it actually is. And in the late 1920s, when Popeye, which is a very famous character which builds up its strength on spinach, came out, it built up this idea further and said that, spinach is rich in iron. And in the late 1930s, Dr. Kern was doing more studies on nutraceutical values of different vegetables, and he found out that there was an aberration in the value of iron in spinach. And it was actually vitamin C, which was more pronounced in spinach. So this just shows to highlight the fact that sometimes mistakes in the data can wrongly be built up in the pop culture and in the day-to-day practice. And it's important that even if we have researched an idea, we continue building upon that and redefine and refine our ideas and concepts about it. So for definition's sake, research is a systematic investigation wherein we are gathering and analyzing information and data, and it's designed to develop or contribute to a certain pool of knowledge that we already have. So we build upon it. Why we need to do research is to validate our intuitions, curiosities, to improve upon the methods that are already existing. It may be the demand of your job that you need to have publications and patents and, it just helps you to grow, not just in your work profile, but also mentally. So it's important to understand difference between research method and research methodology. So basically, when we talk of research method, we are actually looking at all those methods, techniques, and procedures that are applied during the course of studying research problem to attain an answer. So what we are doing is we are looking at tools, techniques, and procedures. While in research methodology, we are referring to a particular research method that is being used. So we are looking at the logic, rationale, and strategy why a particular method would be preferable for the research that you want to do. There are so many preprints, indexed articles and non-indexed articles, but even that comprises of just 10% of what we know. There is still like a huge 90% of iceberg that is not visible to us. So there is a lot of scope for research for all the young minds and for all those who are already doing research, because there is so much unknown in this ever evolving world. So this AIOS endeavor of think under the apple tree is something which I really appreciate, because it brings out more research ideas from underneath the iceberg. It's very important for you to choose a subject idea. So basically, it should be something for which you have a patient pool or some experience, or you have an idea that you can build upon within your existing practice. And if you're reading on something, you find something that can contribute additional aspects or insights to whatever is known. It is always better that you have an original idea, so that there is no plagiarized content or plagiarized concepts that you share with the world. There are a lot of acronyms when it comes to creating a research question. So you can either have a SMART question, which is a specific one, measurable, achievable, relevant, and can be completed within a certain stipulated time period. Or you can adopt a finer approach wherein the research is feasible, interesting, novel, ethical, and relevant. A good research question must answer the PICO. So P stands for patient population, I for intervention, C for comparison, O for outcome, and time. So let's take an example of 60-plus-year-old osteoporotic women, which is the population. What intervention we want to do is we want to give them 60,000 international units of vitamin D weekly. And we want to compare them with age-matched controls who received a placebo. And the outcome would be to say, check out their values on a DEXA scan or see the fracture rate in 2 years of time. So we have an element allotted to each of these PICOT, and that's what you should create whenever you are designing or thinking of a research question. So these are different questions that can be there for your research, and based upon that, you can create a PICO statement. For qualitative research, you can have a spider concept wherein S is the sample, who are the people you are interested in. PI is the phenomenon of interest, whether you're looking at beliefs, attitudes, or behaviors. D is the survey, interview, or focus group, the design that will be, done to carry on the study. E would be the evaluation of outcomes, whether you're looking at feelings, attitudes, or opinions. So essentially in ophthalmology, when we do KAP studies, they fall under the spider category. Or you have to, for R, you have to see whether you're doing a qualitative, quantitative, or a mixed method research. There is this concept of a research onion where there are 6 layers, and each of these layers is pivotal to developing your mind towards that research question and concept that you have. Although research philosophy and research approach, which are the layer 1 and layer 2, are on the outer side, they're quite the core of this concept. So research approach essentially can be inductive or deductive. So in inductive approach, we see a specific observation, we have no preformed concepts about it. With our observations, we try and find a pattern, and based upon that pattern, we come to certain conclusions. On the other hand, in deductive approach, we have an existing theory. Now, I know that an anti-VEGF is going to cause a decrease in the macular edema. So based upon that, I formulate a hypothesis, I collect the data, analyze the data, and then I reject or accept a hypothesis that I had formulated. So there is a preconceived concept that you have in your mind, and it is very important to know which approach you're going to be using in your study. So let's take an example of investigating the impact of digital screen time on dry eye symptoms in young adults. So applying this research onion concept to it. So the research philosophy is pragmatic. What we're going to do is combine objective clinical data with subjective symptom reports. The approach is deductive. The methodological choices are mixed because here we are looking at both quantitative and qualitative data. The strategy is cross-sectional. In certain studies, you can have longitudinal strategy. The time horizon here is cross-sectional because we're collecting a one-time data. And the techniques and procedures include sampling and data collection and analysis of the same. So it's important that you do all this homework prior to starting a study. So any research process involves identifying the research problem, reviewing the literature, formulating a hypothesis, giving us research correct design, collecting the data in the most ethical way possible, analyzing the data, and presenting the correct and appropriate results after thoroughly interpreting them. So we can have a primary research wherein you are doing the research on your patient or a particular topic. A secondary research involves looking at previous data or looking at EMRs from systems in your own hospital. The data can be qualitative or it can be quantitative if we are looking at numerical values. So the primary data collection can be via surveys, interviews, observations, or experiments. And secondary data collection requires, existing sources such as books, journals, databases, and government reports. Nowadays, with the advent of AI application is quite common at all levels of research. So you can have an automated data gathering wherein you're scraping data from surveys or social media, or you can have an NLP analyzing the textual data from interviews and surveys. Two super fundamental principles of whatever research you are doing, whether it's basic research or clinical research, you need to plan, because failing to plan is planning to fail. And you cannot underestimate the value of teamwork. If, as a resident, you have called a patient for a follow-up and you are going to be in the OR and the patient is just going to be lost trying to find you, that's not a good way to do. So you have to have a certain team member who has been allocated to do your work in your absentia, or you should have a sound paramedical support system to take your research in the right direction, in the right manner. Literature search is also very, very pivotal to any sound research method, because your idea has to be original. You have to read all the articles, whichever you can. Recent articles add in more value. And you need to find the gap areas. And I think reading limitations of a particular research add on to more ideas that you can incorporate in your research and fill in the gaps. So you can review the published medical literature on a certain framework pattern like study design, assignment, assessment results, interpret and extrapolate. Don't just read an abstract and try to find out what that study was doing. Please spare a few extra days in reading medical literature before you start writing your protocol. AI application also helps in literature search. You can use the search engines. You can do text mining, or you can use, AI tools which are suggesting relevant research papers. Important to define your objectives in the best way possible. You need to keep your objectives simple. Remember, more the variables, more the difficulty. Don't try to achieve everything possible in this solitary study. You can always have a second phase of whatever you're trying to do. And it is always a good idea to get help at this early stage from your senior colleagues and from experienced researchers, because there is no substitute of experience. What you really should not be doing is writing multiple questions into one objective and forgetting to include the population or setting in your objective statement. Now it's time to formulate the hypothesis. So there are two things. One is null hypothesis, wherein we go with the idea that there is no difference between two parameters or between a parameter and a specific value. And then there is an alternative hypothesis where there is a difference between two parameters or between a parameter. So in our aim is that with null hypothesis, we are assuming that there is no effect of whatever we are going to do in the study. And alternative hypothesis suggests that there is an effect that is existing. So here also, with pattern recognition or data-driven hypothesis, AI can come in handy for hypothesis generation. When you do a hypothesis and you have to craft your sample size, you need to understand the basic statistical lingo. One is the p-value, which is actually telling you probability of seeing your observed results if the null hypothesis were true. Then comes the significance levels, which represent your tolerance for making a false positive decision. So usually it is taken at 0.05%. Then is the statistical power. It tests the ability to detect a genuine effect when it is existing. So when you have an alternative hypothesis which has been proven to be in place, then it is important to have a sound statistical power to that study. Confidence intervals gives you a wide range of plausible values for the study parameter. If you have a very wide confidence interval, your study is not robust. So hypothesis testing process, as I've already mentioned, if you just have a sneak peek at it, it is basically formulating it, choosing the significance level, selecting the appropriate test statistic, collecting and analyzing data, applying statistical tools, be it SPSS or EpiInfo or R or Python, whatever you are comfortable in, comparing these statistics to the critical value or to any standard of care values that are already there, and then making a decision and interpreting your results and then just putting them forward. Here, I would like to introduce one very important concept, that is one-tailed test or two-tailed test. Now, this is basically a statistical hypothesis testing. I am assuming that a drug that I'm giving is going to improve the patient or deteriorate the patient, either direction. So there is only one tail to the outcome. So this is a one-tailed test. If this sample being tested, it fails, then it is falling in the area of this critical region, which is called as the null hypothesis. So here you are having an assumption whether your outcome is going to be in a positive direction or in a negative direction. You use a two-tailed test where you don't know that this drug might improve this patient or might not. So there is a possibility of the outcome being going on both the sides. So the two-tailed tests require a larger sample size and the level of significance gets divided on both the sides. So they are not as robust as a one-tailed test, but if you are trying to generalize a study outcome, then two-tailed tests are better. You also need to know about the alpha and the beta error. Alpha error is the type 1 error wherein there is a false positive outcome. And beta error is the false negative outcome. It does not reject a false null hypothesis. So in medicine, type 2 errors are considered bad. Say, for example, if somebody is HIV positive, but the test kit that I am using is not able to pick it up and I falsely say that this patient is normal, then that is something which is unacceptable. So in medical research, type 2 errors are considered detrimental. You have to choose the right study design, be it qualitative or quantitative, observational or experimental, retrospective or prospective, based upon your research question. So qualitative study is essentially looking at why. What we are doing is observing something, and then based upon that observation, we are giving our interpretation. Qualitative, on the other hand, is asking how many, how much. So basically, there is a numerical or a statistical value which is there, and it requires a statistical analysis. So research studies can be exploratory, descriptive, diagnostic, hypothesis testing based upon your research question and your population setting. It's important to understand what is independent variable. So say, for example, I want to start a new drug, which is Ripasudil, and I want to see the effect of Ripasudil on the intraocular pressure profile. So here the independent variable is the institution of the new drug, which is Ripasudil. So that's the cause. And the effect is its effect on the intraocular pressure and on the cornea or any adverse effect profile. So you need to define your independent and dependent variables carefully. Now, which study design to choose? Now, if I want to increase my knowledge of a disease or of an exposure, and I want to develop a hypothesis, so for me, a descriptive study design would work. If I want to investigate a disease's relationship to the outcome, then case control studies. If I want to understand the meaning in relation to an exposure, we need to study this thing for a longer period of time than a cohort study. And if I just want to test link experimentally, a clinical trial is what I want to do. So just have a quick look at what are the different options. We can have an observational study or an experimental study. We can have a population-based or an individual-based study. which can be descriptive or analytic. So remember, if your questions are who, what, when, and where, you're looking at a descriptive study. And if your questions are why and how, we're looking at an analytical study. So quickly, let's just have a look at the different type of studies. So cross-sectional studies are basically observational studies. The study is happening only at this time point. It's not going to be followed over a period of time. So we are studying exposure and disease status at a single point in time. The cross-sectional design is essentially like a snapshot. We are studying at this time what this patient, what this study population has. So for example, if I'm looking at ARMD patient now, and I'm trying to see how many of them have an influence of a period of smoking in their disease outcome, I'm looking at cross-sectional design for this particular research idea. The case control design, on the other hand, has two things. One is study cases, which are representative of all cases of a particular disease. So herein we are talking about cancer patients. We take their history. We're trying to say, pick up one factor, say, I'm trying to see whether water from a particular region is contributing to a particular type of cancer. I'm also picking up a comparison group from this same population. I'm taking their histories and seeing whether they were also taking the same water. And based upon their comparative histories, I'm coming to draw a conclusion. So remember, the controls have to be from the same population. Multiple controls can be used. If you're using more than one control group, your credibility of the results is more. Cohorts design, on the other hand, has multiple observation points. But remember, at baseline, all the subjects here are disease-free or free from the outcome of interest. The exposure over a period of time is used to classify these subjects into exposed or unexposed. So subjects are followed up for a longer period of time to document incidents. So you can have nth observation point. You know, studies like ocular hypertension study, they've had like one data set point and a second data set point, and then you can have a post hoc analysis of these studies to give you more information about these patients over a very long period of time. So cohort studies begin at this time when the study population is disease-free, and as the studies continue, you look for the factors which you are trying to look for, and then see what is contributing to disease or no disease. The cohort studies can be prospective or retrospective when we are trying to look back and look how a particular outcome, how a particular exposure could have influenced the outcome. Cohort studies are important for longer diseases like ARMD, glaucoma, or if you're looking for certain changes in cataractus patients. So they help to identify risk factors and disease progression, but the only drawback is that they are time consuming and maybe expensive, and sometimes, the population can just fizzle out. When we talk of experimental studies in relation to ophthalmology, you have a treatment group and a control group, and you follow them up and compare your results. So you're giving them a drug and then randomizing it and seeing the outcome in these patients. It's important to understand the concept of masking and blinding. Unblinded studies are open label studies where everybody is aware of what's happening. Single blind, only the participant is unaware. Double blind, both the participant and clinicians are unaware. And triple blind, participant, clinician, and the data analysts are unaware. So quick recap, which study to do when. It's important to correctly choose the study design. You build up on the hierarchy of evidence. There are no humans involved. That forms the animal and the laboratory studies at the base of this triangle. Then comes the case reports, and the robust ones are the RCTs, and over that you have the secondary or the appraised data, which is the meta-analysis and the systemic reviews. So it's always a good idea to do a pilot study to understand your limitations, and it sometimes gives you good ideas to finally draft a good protocol. Analyze your data, both in terms of quantitative and qualitative analysis, and this is something which is going to be covered in the subsequent webinars. AI can be applied. You can definitely use machine learning, predictive analytics, NLP for statistical data interpretation as well. Look at the effect size, not just the p-values. Always document assumptions and limitations. This is something that Dr. Narayanan has also mentioned. Validate your results with follow-up studies. Write a good research paper. immediately after your research has concluded, because you are fresh with all the interpretive element of your data that you have collected. And in the end, I would like to conclude that be open to adapting your research design as new insights emerge, and you start analyzing your data as you collect it, because intermediate analysis gives you additional insights, and sometimes you may require to check certain data for its repeatability, regularly review and adhere to all ethical guidelines. So with this, I hope you all contribute to existing literature pool with good research. Thank you very much.
Thank you so much, Dr. Parul, for such an elaborate talk. May I now invite Dr. Kasturi Bhattacharjee ma'am, Dr. Rajanaran sir, Dr. Usha ma'am for their expert comments, or if they would want to ask any questions to the speakers for the benefit of the learned audience.
Thank you so much. I'm very happy to actually have heard this talk, quite detailed. I think it will need some time for the audience to, if they go through this video recording, then they can assimilate more. But if I have to just add a few points, which was uh, actually mentioned also by Dr. Parul, I just want to re-emphasize. One is she mentioned about effect size and not just the p-value. It's such a huge statement she has made that deserves itself by another 1 hour of probably talk. What it means is that, let's say in stock market or mutual fund or any investment, you ask for a return, right? So if I invest 100 rupees, am I going to get back 1 rupee, 5 rupees, or 10 rupees? And only then you invest. But in science, as of today, this p-value which is being quoted so often, and anything which has a p-value less than 0.05 is published, and we also publicize everywhere that I got this publication, does not tell anything about the return on that treatment. Whether you are getting 0.5% return or 1% return, even 0.5% return can have a p-value of 0.00001. And you can try to sell it to the patient also. Just for example, if the visual acuity of a new intervention, new drug improves the visual acuity by 1 letter, and the p-value is 0.0001. Now, the entire medical fraternity goes after the p-value, publishes it, the journals publicize and publish it. But that 1 letter has no meaning for the patient as an outcome. It's like almost no returns on my investment. Only side effects. I can have bag full of side effects and no return from that intervention. So unfortunately, this, as I said, we cannot explain this in just a few minutes. It requires a big class by itself. But I just want whoever listens to this talk by Dr. Parul today, that one line, effect size, is the actual return on investment, which we all should look for. And that requires a lot of knowledge. We go undergo post-graduation, fellowship. If it's just p-value, we don't have to do so many years of training for doing these things. But yes, I don't want to elaborate more, but that was a very important line that she mentioned.
I would also like to add one thing for the benefit of the residents, that it's not important to have a positive outcome. Whatever you're anticipating, it's not necessary that that comes out as an outcome. Unequivocal findings or even negative findings, the unanticipated ones, also need to be presented the way they are. So research is not supposed to please anybody. It is supposed to present what actually exists. So that's something that forms the basis of ethical research. And that's something that needs to be remembered by the younger residents, who are just writing their thesis or dissertation. So it's very important to remember that.
Do we have some comments from Dr. Usha, please? Dr. Usha Singh?
I'd just like to listen and assimilate what Parul has said. Most of us are using most of these methodologies, and we are incorporating all these points in our research. But yes, to present it at a forum like this, the concentrated way, we need more time to assimilate. So I think Dr. Rajendran has very well pointed out about the point he just spoke about. So I would like to leave it at this right now. Yeah, maybe Dr. You can comment on it.
Yes, I would like to just follow up on what Dr. Parul mentioned, that you need not please anyone. So as of today, we look at research, the outcome is publications, and that is used for promotions, awards, getting on stage. That's trying to please yourself also. But the most important person in all this research is the patient, nobody else actually. So for all practicing people, whether you are in private practice, have nothing to do with academic publications, I would say research is so important for the benefit of our patients. Even if I am in private practice and I don't get more money out of doing any research publication, but to at least go through research and maintain your own records to see how my patients are performing with this particular treatment, that itself is also research. Not every research has to go for a publication or get an award, but knowing what is happening with my patients is extremely important, and that is why research is necessary. So we need to dissociate publications from research. That is a very, very strong connection which people have, and publications get, I know people who get put off by publications actually, that these people are chasing the wrong thing. In a way, I sympathize or empathize with them, that we should not run after the publication just for the sake of it, but the research should guide us to improve our patient outcomes. Very well said.
Exactly. When I agree to you, whatever like we learn or we earn, we have to give back to the community for the safety of a patient. Very well said, Dr. Rajanarayan. Can we hear a few comments from our two young panelists, Dr. Rolika and Dr. Sonali? Sonal?
Sure, ma'am. Ma'am, I actually love the example that Parul ma'am gave about the spinach and how the Popeye spinach correlation. I think it connected the audience pretty well. They were able to correlate how exactly to go about the process. And many people ask this question, that how do I really find a research question now, so that so much has already been done? And I think that what Dr. Rajnarayan sir said just now, it has to be kept in mind that when you have so much literature available, and when you're looking at the literature review, pause for a minute, think about your patients, about what is available and what needs to be done, and how you can be a little creative, and what more you can add to the literature in the existent pool. It's not necessary for you to do a paper or a research based on what is available already. The current literature is like a step stool for you to, a stepping stone for you to write your future literature. And that should benefit. And if it is not benefiting, then it's of no use. As Sir just mentioned, that if it's not benefiting your patients, it's not for you to get an award or for you to get a promotion. So if you have the correct ethics in mind, it will lead to a good outcome.
Thank you, Rolika. Dr. Sonal, please.
Yeah, good evening, everyone. So after these two excellent talks and such a nice discussion that Rajanayan sir has done, I just want to ask all these stalwarts present here that how much use of artificial intelligence, I know I'm opening a Pandora's box, but how much of use of the artificial intelligence is considered to be like, crossing the line and not crossing the line? It's being used almost every year. So what do Parul ma'am and Narayan sir have to say about that? For research purposes, even the review of literature and everything, how much is right and how much is wrong with the writing and everything?
when we are looking at the generative AI that we are using to find out the articles, at the end of the day, you are going to be reading the articles. It has just helped you to find the article. So there's nothing unethical about it. Even when you're using a statistical tool which is using an AI, at the back end, the AI is using Python for, say, for example, if we talk of ChatGPT, it is using Python at the back end to analyze. So whether you use an SPSS or a Python or anything, as long as you are mentioning that, now it is considered acceptable that you write in your methodology that generative AI was used for the analysis of the data, as long as you are mentioning what AI element you used and for what purpose, it is decently ethical. I'm not saying that we get paraphrased literature, you write your paper which is paraphrased by the AI tool and then published, that is unethical. But the statistical element of it or finding the articles, at the end of the day, you are going to be interpreting the stats. You are going to be reading the articles. So as long as you write it, it is within the ethical limits.
Ma'am, do you also think that the analysis that comes out of AI is actually sometimes inaccurate? Like in my personal experience, I tried to search. I was just checking that I've made a table of articles. I was just checking if it's been made correctly or not. And when I put in a prompt to, give up the articles on some particular disease, it was giving wrong articles. Do you also experience the same?
Yes, I do. It's not robust at the moment, but giving the right prompts also comes to us with time. So it just gives, sometimes you use your own basic research methodology that you use otherwise, but you can just aid with the AI tools that are available. And sometimes you may find something additional that you would have missed out. We cannot totally depend on an AI-driven research steps to be sure that we are doing everything in the right manner. It can just add on to the information in the current state, but as we learn to use the correct prompts, the research outcome gets refined.
From whatever little that I have used AI, ma'am, I felt that I'm not saying that it's unethical, but I found a lot of wrong answers coming, and sifting through those wrong answers was actually more difficult than doing my own research. So then I realized that
writing the correct prompts is the
Yes.
correct way to go. Yeah. So if I want to write down that I'm looking at a research methodology presentation directed for ophthalmology postgraduate residents of final year who have already written their dissertation. So I've expanded the entire statement in the prompt, then the outcome is going to be better rather than just writing down research methodology for ophthalmology. So the more we expand, the more the research gets refined. So these are just stepping stones into the AI world, and I'm sure over the years, all these chatbots and everything and the LLMs are getting refined day by day. In future, this is something that should be kept in mind because it takes care of a lot of time that is invested into research. So if you can automate some of the steps and do a more fruitful work additional to all these things, then I think it's something that we need to learn. That's why research is also a learning process. And we are refining LLMs, and that should, in future, add on to our existing knowledge.
I agree, ma'am, that the correct prompt is necessary, and the postgraduate should also keep in mind that AI is very creative. So I have also seen it create citations and articles which do not even exist.
Yes, agreed.
So it mixes up. So please be very careful, because I had reviewed one of the papers in which a citation was mentioned, and I said that is not possible. And then when we verified with them that was AI used, they kind of agreed on it, and we had to reject the paper. So go through the creativity of AI also.
Thank you.
I would just like to add that
I asked Grok, the Twitter AI, I asked Grok regarding some publications of particular author, and a list was given, and among those lists were this particular author. And then when I started checking, half of them were not existing. So it's very creative, I think. It's able to take in and
Usually when we submit any abstract also from some of the very important conference like American Academy, like they usually ask us whether you're using AI. So in case we use AI, they are usually not very acceptable.
Yeah,
So
I would like to just mention that, the biggest danger worry is that whether you can claim to be the first author and you yourself don't understand what are the results. AI can give you predictive values, sensitivity, correlations, regression, R value, but if you don't understand or we don't understand what is the meaning of these and we present, that's is absolutely unacceptable territory for any journal, and that's what we need to look at. So if I can have these statistical tools, Dr. Parul was mentioning a lot of things we can use. Yeah, it can write the code for multiple analysis or in SPSS or whatever you want to do. But as long as I know what it is and what is the meaning of the result, it's improving my efficiency or cleaning up my English language. So in my introduction, I need, doesn't look good. I tell LLM that, please improve the English language in this introduction. It can give you back something that is still acceptable. Or let's say the journal says the introduction should be less than 500 words. It's currently 600 words. That's fine. It's still, but you are owning whatever is being written. But if the author doesn't even know what is being written by AI, that is totally unacceptable and dangerous. That is where we are at this point of time. This today's session, which we are having, is to understand research. AI probably comes a little bit later.
like BCBR by NMC has made compulsory for all the residents. And that has been a very positive step. Like I think it came only from 2019 or something. So, I mean, like in our institute, even not even the residents, we also make the consultants go through this
Right,
BCBR.
compulsory for faculty as well.
Yeah, it should be for the faculty also. And this has given a very good understanding about the basic research, how we go ahead with the different studies and how to genuinely understand what he or she is doing. So I think with this is very interesting. We can keep on discussing, but we have to wrap up. And thank you very much, both the learned speakers. We have learned so much. And also, I should thank all the enthusiastic and the curious audience. They've stayed back with us. And so, as we wrap this session, I'm sure we are all loaded with knowledge more on research question. And next 24th of April, we have the second, webinar that will be covered by Dr. Kirti Singh from Delhi and Dr. Sunny Sen Gupta. So we have two important topics next on 24th. I request all of you to join us. Until then, we meet again and happy researching. And thank you, everyone, all the faculty, the young panelists, Dr. Shubha for moderating it so well, and definitely Dr. Usha for being the chairperson of today's meeting. On behalf of AIOS ARC, thanks to all of you.
Thank you.
Thank you all. Bye.
Thank you so much. Good night.